discuss with you some we think is the important aspect in developing an efficient biomarker discovery and to the validation pipeline. A lot of those points what I'm talking about, I'm going to discuss actually a lot of Pat is already touched, kind of show you some data and then give you some, already show some kind of what he's thought about his experiment. The most of experiments were done here actually when I was in Dr. Jennifer Vag's lab, and then so it was in collaboration with Thermo. By then I was in Jenny's lab, it was in collaboration with Thermo. And then since the end of last year, I joined the Thermo, but we still collaboration. So for new data I'm showing is also collaboration with Jenny and then Thermo, except I am in Thermo now. So for this audience, we all know that the biomarker discovery, validation to the clinical utility, it takes a long time and takes a lot of money. And it's just, everybody want a new biomarker, everybody want a really good new biomarkers, but it takes so much money, it takes so much time. We want to have a better markers. So in 2014, and actually a group of proteomics expert, and then they together and then give us sort of 3 tiers of assays in biomarker research. And actually that's kind of sort of a standard right now for 3-tier of assay, is that in terms of what kind of quality, what kind of technology, as well as what we're really looking for, what are we really after. So for this 3 phase, you all know from discovery to verification to validation, and then to the clinical utility. And then for those 3 phases, you can see that usually in the classical we think is the analyte from high to low, and the sample from low to high. So for example, tier 3 assay is untargeted, is mostly we're doing discovery analysis such as DDA, DRA. For this is a really exploratory experiment. We don't have an internal standard. Usually we don't have an internal standard such experiment. We usually get a low to medium precision in the discovery. That's I'm called a tradition. So I'm gonna show you some data, actually get the really good data from innovation of technology, a new mass spectrometer. So for this, in the beginning, in the early on, we're really looking for large magnitude change. We're looking for disease control. We're looking for large changes. And also for the analyte, traditionally, we're usually looking for hundreds or thousands analyte. And then, of course, there's no reference for certified reference. For tier 2 is more targeted analysis, such as a PRM, MIM kind of assay. And it still is research grade. Sometimes it does have internal standard. It's looking for is moderate to high precision, and then there's no documentation in the QC procedure still at the tier 2. And it is really looking for the tier 2 kind of assay, is looking for trend repeatable. So we're really looking for trend, are they elevated or they are decreased? They're looking for the trend repeatable. And analytes slightly less than discovery stage is about 10 to 100 analytes. And again, for the reference is a really limited reference. For tier 1, probably everybody, audience here, most people probably know the tier 1 clinical utility markers much better than I do, because I'm still in the research world, so you will know this better than I do. So this is with a very high quality kind of analyte. It's clinical use, it has a really good, has an internal standard, has a really stringent quality control procedure. The value really should be repeatable. Now the trend is repeatable, the value should be repeatable. And then the analyte right so far is really only 1 or 2 few analytes, and then of course you need a certified references. So for biomarker, actually, whether it's a discovery to the validation, the process, actually, the pipeline is very, very much similar. We take a biological sample, we digest with enzyme, we separate on HPLC, and then we use mass spectrometer to detect the signals. And then we do bioinformatics, do a data analysis. The difference here, actually, the difference between the discovery versus the validation really is the what sample to use, the throughput, the mass spectrometer to use, like in the discovery and the validation. For the HPLC, actually, I'm going to talk to you about 2 examples from discovery to validation. We use the same HPLC, NeoVanquish. It really does the job for both. For each step of this process, from sample to the data, really for each step, we really need to have a very specific requirement or specific things in our mind we want each step to accomplish. For example, the automated sample prep, we want to have a platforms which has really have a versatility. We want to really hand off free as much as we can. We need to have a scalability, and then also have adaptation, which means we can adapt to different sample prep with the IP, non-IP, different detergent, precipitation, et cetera. And the most important from all those immediate sample prep is consistency. Actually, I'm going to show you a little bit data of why this is the case, why really we want consistency. For mass spectrometers, whether it's discovery or validation, we want to have a sensitivity, specificity, quantifiability, robustness, and reproducibility. So in all the steps we ask, each steps we really want to, we talk about optimized pipeline, right? The optimization, the steps is really to minimize analytical variability and maximize biological variability, like Pat was just discussed. So I'm actually gonna walk you through those steps, just in general, what we have seen and what we were done. And this is slides everybody probably know it came from the, you probably see all kind of format, but it really is say the Y, large scale LC-MS-based plasma. Protein quantification is really difficult because of dynamic range, because majority of the protein in the plasma really only a few high abundant protein. Those low abundant protein is a very small amount. Human proteome is complex. We are all bred. We have unique, each of us has unique genomes. Each of us has unique proteome. In the database, the database we have currently document about more than 20,000 protein. If we plus the isoform, more than 40,000 isoforms. If we do a theoretical tryptic digestion, in silico digestion, we got more than 1 million peptides. So that's really a lot of peptides we are looking to go after with mass spectrometers. And all of those, because there's many years of research, there's a lot of those proteins entries actually really have documented in the literature, in the database. It has, for example, there's about more than 18,000 entries from this database with proteomics data, as more than 5,000 entries with some kind of associated with some kind of disease, and more than 70,000 proteins, which is really have a biological process. However, the entire human protein is complex, but if we look at just a single protein, is as well as complexity too. So this is a typical example of a urine protein, a purified synthetic urine protein, and then digested with trypsin, with the 1 microliter trypsin or 4 microliter trypsin, and then look at the MRM signal of the 12 peptides. And then if the tryptic peptide are equal, it's the tryptic, the site are accessible equally, we should expect that all the peptide ratio is the same if we compare the ratio between 1 microliter versus more trypsin versus less trypsin, but we don't. As you can see here, actually is this 9 peptide, they behave pretty much same. They are kind of same behave, so we can use them to quantify the protein, but this 3 peptide obviously not. So when we quantify the choice of peptide which we use, it's really become very, very important, which peptide to choose to quantify this protein. And I'm gonna talk a little bit of the solution we kind of come up with when we look at this Astra data. This is actually my favorite experiment to show that there is a necessity of automation. Yes, automation can save labor, automation can save time, but automation provide actually the most value is the consistency. The reason tell you why. So this is the experiment we did back in the beginning of develop automated sample prep is take 160 cells, spike in the plasma, and then let it simple digestion, not complicated, let the plasma reaction go 2 hours, 4 hours, 6 hours, 10 hours. And then we look at the MRM signal of those cell signals. It's not even endogenous peptides, cell signals. As you can see clearly here, the signal of the cell has dropped when the time goes along, and that is targeted very specific cell peptide. And then not only that, if we take a different cell, different peptide from the same protein, and you can also see the degradation of those cells is very different. The kinetic is different. So, we should expect that because the human plasma has, we add a trypsin, which is specific reaction, but we add but also it contains the peptidase. We all know plasma has peptidase. So this provides they provide a non-specific digestion. So there's a really 2 reactions going on in the trypsin when we're trying to digest proper sample. One is specific, one is not specific. So that's really bringing up the automation. Robotic is essential for these large scale study. The reason is that we have no matter how good we are with hand, we pipetting from well number 1 to 96, column 1 to column 12, play 1 to play 10. We cannot really keep the timing consistency when we go through all those steps, the denaturation, alkylating, reduction, all those steps. It's really, really hard. But the robot can do it and do much, much better than we do. And if we give a robot a same set of protocol, And we've used a large scale study, and we use the same method, so we get very consistent results. So we don't need a perfect digestion, but we need a consistent digestion. That's kind of lesson we learned from our this experiment. So which means actually at the beginning of your biomarker research, like your validating or discovery, you really need to know your sample. You need to have a sample, you need to know your sample type, you need your age distribution, gender distribution, and all the other clinical parameters. The reason is because of we want to minimize analytical validation. In order to do that, the first step is we need to randomize. We learned that we need to randomize all the samples at the very, very beginning in the digestion plate, because LC-MS injection is sequential, unlike ELISA. It's a parallel reaction, but the LC is sequential. Sequential reaction always have drift, right? So we should minimize when we do the preparation for the sample digestion, we need to minimize that kind of technical and the analytical variability, so then we can maximize the biological variability in the very end. So here is a show example. We not just randomize, or we do a randomize equally blocking into how many samples you have and then how many plates you have. And then in order to monitor the digestions, usually we add a QC, some control plasma, same plasma, in like a different location on the same plate and in the all plate, and monitor those QC samples to look at the digestion consistency, as well as to monitor analytical variability. And then we also like to put a blank and one well asymmetrically, only because 96 wells, sometimes we flip orientation. With that blank, we really can catch we can catch if plate get accidentally flipped. So for the LC-MS, we always need to have a system suitability SST injections. We need to have, and in the end, we have a way to really looking at the digestion LC-MS performance evaluation. Then you really have to look at those first before we really dig into the biology. The reason is, if analytical variability is so big that is above the biological variability, then those kind of data is very, very hard to come up with real biomarkers. And this is just give you example of the automated digestion we did with one of the robotic platforms. And then the red bar is just show you the manual digestion CVs, which is decent. And the green bar is show you we take the manual digestion process, throw it on the automated platform, and then without optimization. And then actually CV is not better, even worse sometimes. The blue bar is showing the automated digestion with optimized protocol, because those liquid handler really need to be optimized, how this pipetting goes and all those times, and then the techniques, we call it pipetting techniques. And the monitor, this is use the 2 peptide from the exogenous spiked beta gal and the 2 peptide from endogenous human plasma. So the graph on your left actually show you the online SPE desalt procedure we had. We had also automated desalt method. The red bar represent the total CV came from the SPE plus LC-MS, and the green bar represent LC-MS CV. So the difference between red and green is really the SPE CV. So again, for the automated reaction, we're really looking after is consistency. Digestion doesn't have to be perfect, but had to be consistent. That's kind of a lesson we learned. So then, actually, about 2 years ago, I was in Jenny's lab. We got really lucky to get opportunity actually looking into the new mass spectrometer. Astro was just ready to be launched, and then they say, oh, we needed someone to just really see how plasma works. So that's we started collaborating with Thermo at the time, 2 years ago, to looking at the plasma digestion, plasma performance on Astro, as well as use that as to do a real biomarker discovery. So in the beginning, we did a 3 throughput, 180 samples per day, 100 samples per day, and 60 samples per day. And then we look at the numbers, did a loading curve, and then 3 different color on the bottom bar is represent the 3 different throughput. As you can see here, total numbers, actually they are pretty, they behave pretty much same. They increase when we have more loading on the column. And the median CV, the precursor in the middle one, as you can see here, they're all decent actually, but you can see again the 60 samples per day actually here is to show the difference is better, less CV. For completeness, which means we observe them 5 times out of 5 injection. They are pretty decent actually, 5 times out of 5. 90% precursor we see 5 times the 5. And then if we look at the completeness plus the CV, and we can see the three throughput are different. So in the end, we choose 60 samples per day for our real biomarker discovery because we all want the speed, but also we want the quality. Quality first, then speed. So this slide's kind of complicated, but it's actually, the message is quite simple. The information you get from this is very simple. I'll walk you through. So here, just the digestion. I talk about digestion, which we use the digestion optimized method, the random blocking, randomize and blocking the procedure for digesting. This is 500 subjects, about 300 controls and 200 IBD example, inflammatory bowel diseases cohort. And then go through the 60 samples per day with Astro, with NeoVanquish, and then the search is done with the user Dian search engine. So the first, before we dig into the really biology, is we really want to look at the quality of those 500 injections plus loading curves. So this is what you see. For 500 samples, 6 plate, is that we got a very similar precursor numbers as well as the protein numbers. So at this point, we kind of relieve, we don't see the batch effect. That's kind of it's really tough to deal in the end. We're really looking for biomarker. And also we look at the intensity from 6 plate to the PCR analysis. They look pretty much overlapping. So we really don't need to worry about the batch correction for this particular cohort, these injections. And then this is another way to look at the data is to bucket all the control sample together or IBD together. This actually was a pleasant surprise for me. I was really happy when I see this data. What this does is we actually spiked IRT into each of the 500 samples, and then use a search engine, we got IRT retention time intensity. And this is actually retention time plotting of 500 samples of 11 IRT. And then the retention time, just you can see that retention time just rock solid from the sample number 1 to sample number 500. And you can see a little blip here. This is actually that particular sample. When I look at detail, the particular sample has like a 1 minute retention time shift. And then we look at the total tick slightly off on average, and the total precursor peptide number also off. So this sample eventually got eliminated. And then so after we're comfortable with the acquisition method, then we say, okay, those 500 data looks really good, and now we need looking for biomarkers. So when we start looking for biomarkers, we actually analysis the data set with so many different ways. You know, we go left, the right, the top, bottom. And in the end, that's where the targeted extraction assessment quantification kind of package come about. The reason is because we know how much work is in the end if we want to develop a really solid validation PRM or MI marker in the validating a very large scale. Knowing amount of work in the downstream, we see in the upstream discovery, we really want eliminating false positive. We want to get as solid positive biomarker, potential biomarker as positive as we can, you know, as convincing as we can. So we developed this pipeline is just really bucketed the protein peptide precursor identified from discovery from Astro data into different buckets. For example, total is a total ID the protein, and then called a reliable ID the protein, which is identified in 60% of a repeated injection, and then which is a 3 out of 5 injections. And then we have those precursor proteins which has the low LOD, CV less than 20%, and the LOQ which is adding the linear regression concentration across 3 concentration with CV less than 20%. This defined by a loading curve. In the end, the most important part is signature peptide bucket, which is these are all with LOQ, no miscleavage, unique peptide sequence in FASTA database. The most important part, the Pearson correlation of the different peptide within a protein across 500 is more than 0.7. And then this is actually, signature peptide is defined by cohort as well as loading curves. So this is kind of a fun way to look at the, when we started to kind of bucketing all those precursor peptide protein, what do we get? There's 3 different color represents 3 different throughput, 180 samples per day, 100 samples per day, and then 60 samples per day. And the different, then this protein, kind of protein block, peptide block, and the precursor block. And the different bar colors, light to dark, is from total ID the number to the number with LQ. For example, protein, you can see that for 60 samples per day protein, we total identify more than 1,200 proteins. And then when we do the protein evaluated with the protein with LOQ, is about 300 proteins. So this is the discovery stage, right? We went through all the discovery and then do the Astro discovery. And then the TEAC is stratified discovery data from more than 10,000 precursors, more than 8,000 peptides, more than 1,000 proteins into more than 1,000 signature peptide, and more than 300 proteins. And then, so here's the summary of total ID the protein, and that's about more than 200 with the p-value, good p-value, between the IBD and the controls. And then that's a 148 with LOD value, and then 98 with LQ value, and then in the end, we have 97 protein with signature peptide. So this is really first tier of the protein to make PRM assay in the downstream. And then that time we were lucky, actually that was last year when Stellar was launching. And again, we collaborated with the Stellar team in San Jose, and then to do the IBD, those biomarker validation. And then the first validation we did actually didn't use the IBD, the novel biomarker, which actually Jenny actually will be talking about in the science session but it's used pre-made in the lab, called the health surveillance panel, which has these 57 protein and 83 peptides. And then we used this hybridated Stellar is with not just, it's really specialized high throughput targeted assay, and also what is unique about Stellar is the PRM conductor, which has talked in his talk. This is that's a really game changing. I think that's really game changing for the large scale targeted scheduled assay. And then also the Stellar we evaluate before the launch, we evaluate the reproducibility, data quality, sensitivity, linearity, precision, multi-day reproducibility, and as well as a take on to the IBD expanded to the 1,000 samples. So if you want to know more details, actually Jenny gonna give a talk in the science session. She will give a whole lot more data, as well as more exciting new data coming out of her lab. So again, the PRM conductor, I think this is really game changing PRM conductor for the large scale scheduled assay, because enable the adaptive retention time, sort of adapting retention time along the way. To give you just example, for example, this is plane number 1 and plane number 3, that particular peak. Plane number 1 is 3.7 minute, plane number 3 is 4.1 minute. Because of the PRM conductor, because of adapting retention time kind of along the way, we actually did not miss that peak. We still catch that peak, within this 1,000 samples. Here, just a very brief summarizing of the PRM, PRM validation study uses Stellar with 1,000 samples, and in 1,000 samples we end up actually is 2,000 injections, because we add like a high-low median QC SST, the wash, solvent blanks, and the PRTC blanks. So in the end, it become a 2,000 injections. Again, if you want to know. There's a whole lot more data, and actually is really, really nice data coming up from this study. And you can, so you can, Jenny will talk more in her session. So this actually, I want to show you actually first when we did the Astra discovery, we found this A1AG1 to be elevated in the IBD samples, and then in the Stellar validation 1,000 samples, and we also see validated this mark. So that's pretty exciting actually. When I see this, that's pretty exciting. And the CRP is similar, and then it was found in the discovery data to be elevated IBDs. And then in the validation is also elevated, but here is the data, the acquisition done with the MS3 CRP. And actually, Jenny will talk about a whole lot more of the CRP data in all 1,000 samples, distributions and CVs is really nice data set. So this is when I see this, it's making me really happy, because this is the same cohort. We did a 500 discovery, and then we did a 1,000 validation, and then there's more. Of course, the real IBD is still going. Real IBD market is still going on in Jenny's lab. So now I'm going to switch gear a little bit. I'm talk about a third innovative technology, which actually is a source, called the OptiSpray ion source, which is still undergo the technical review process. For this source, it's very much hand-free. It's very easy to use. And its performance is really, really good, because it's all in one source for the calibration, for optimization, for the acquisition, just one source. Not only that, the emitter is automated position. You don't have to go eyeballing left, right, up and down. It's just you push this automated optimization, the emitter will find its right position for that particular MS, And it's really simple. The only thing is a plug and play kind of source. The only thing changed actually is the cartridge. for different columns, and also you can swapping of the emitter and keep the column. So because if the emitter gets older, gets not as good, you can just really just swapping off the emitter and it keeps column. And also in the software keeps tracking on how many injections you can do with that particular column. And also it has a really nice blue image on the software. It'll show you the spray cone. That show the spray cone. And also it also reliability because the emitter moves off the active spray position once after run is done, and with the next injection, they're moving back to the active source. It's really that keeps MS clean, so it's really neat. Here, just I show you a data on the ultra spray with the 3 different samples per day PR method with Stellar, and again with 83 cells, and you can see the intensity-wise for 3 different throughput and the points across peak. They are pretty decent, and the CV is pretty decent too. Notice the CV, actually you can see the early elute and later elute, those CV, those are the peptide probably need to be optimized later in the gradient-wise. This is show you if we compare the Opti spray with the Easy spray, and then the green represent the Opti spray and the purple represent the Easy spray. As you can see here, the intensity slightly increased for all throughput, but it's really not game change. That's a 1 log change that slightly increased, so it's not a big change. But the CV, it's get better CV. For 100 samples per day, CV sort of similar, but for high throughput, the CV gets better, use the Opti spray. They get a decent LOD, LOQ, and the linearity. As you can see here, for this 83 CO, the majority of the LOD is less than 0.5 femtomole on column, and the majority LOQ is less than 5 femtomole on column, and then everybody has a linearity R squared more than 0.9. And you can see here's beautiful peaks coming from use the Opti spray and a Cal curve. That's just the example of Cal curve 1 peptide. So now actually is coming back. In the beginning, I was talking 3 tiers assay, right? In the tier 3, we have high quantity, low quality kind of result. In the tier we want to have a high quality but a low quantity kind of assay going. So this innovation technology, those new mass spectrometers, the new technology, what can bring us is provide some tools. The tool is counterbalance quantity and quality, so that tools provide is to give a balance of we can keep the high quantity as well, we keep the high quality. So I talk about Orbitrap Astral as a new discovery platform, and Stellar as a new validation platform, and also this new source. It's just a thermal. It's going to be launched soon, but it's right now it's under technical evaluation. Is the Opti spray source, and plus bioinformatics. All those tools provide a counterbalance. Why is that? The reason is really don't come up with summary is that all this new technology, this innovations, this in all hardware, software, is really provide a paradigm shift in biomarker translation. Now we can do this technology allow us to do larger scale and high throughput LC-MS. And high quality with speed and the scale. So really, in the end, what we really want to do, we want to shrink those 3 phase short. We want them overlapping, we want to shrink them short because we want to reach a real biomarker sooner than later, and we really want to see the promising of the future medicine. This is all my science talk, but